Welcome to our next session. Got three talks coming up. Very topics. We're very excited to hear that.
Hello.
First, we have Dr. White, who received his undergrad and med school degrees from Harvard.
Can anybody hear me? Should I start talking, or is someone going to introduce me?
We can hear you. Can you not hear us? Can you hear us now?
I'm sorry, I cannot see the audience, and I'm not hearing anything from there. I cannot tell if I'm supposed to be talking or if someone is going to be introducing me. Because if I'm supposed to be talking, would everybody please stand up and wave their arms, just trying to fix. Thank you, Manisa. Okay, hello everybody. Greetings from sunny Dallas. I am sorry that some circumstances prevented me from coming up there, but I'm happy to be speaking remotely. I apologize for the audiovisual problems, which aren't my fault, but I apologize anyway. I'm going to be talking today about congenital adrenal hyperplasia, and if something happens to the AV, please, Muniza or someone, just send me a text. I will keep my phone here by me, and I will try to go back or do something similar to that. If I need to hear you, I imagine we can do something by telephone as well. So this is a talk on congenital adrenal hyperplasia, and we're starting 12 minutes late. So I'll try to take us to the top of the hour, and I will, as I usually do, try to talk fast. Disclosures are that I am a consultant for Neurocrine. I received sponsored research funding from Neurocrine and Diurnal. I have funding for CAH from the National Institutes of Health, and I don't know, I will be discussing off-label treatments. So this is a slide that I've used for probably about 30 years, just showing the biosynthetic pathway from cholesterol to adrenal steroids. The idea being that physiologically relevant steroids are made in the zona glomerulosa, fasciculata and reticularis, aldosterone being the main salt-retaining hormone, cortisol the main stress hormone, and androstenedione, and androgen and a precursor of testosterone. There are multiple enzymatic steps here to get from cholesterol to these various steroids, but the one that's relevant here is 21-hydroxylase. If you have 21-hydroxylase deficiency, that's the most common form of congenital adrenal hyperplasia. You can't make cortisol. In the severe form, you cannot make aldosterone. You get accumulation of precursors proximal to the blocked step, with shunting of precursors over into the pathway to dehydroepiandrosterone and androstenedione, which causes all kinds of problems. I don't know why this is advancing automatically, but this is a slide from an Endocrine Reviews article that many of you guys have seen, just to show that this has become, I see something from Muniz. I'll hold for just a second. Your display slide is not too big. I'm sorry. I mean, it's showing full screen. Bear with me just one moment. Thank you. That looks right. Is that better? If this doesn't work, is okay, it's good now. Fine. Thank you. Going back to this other steroid diagram, this is published. I'm not going to go through it exhaustively, but just to indicate that our current understanding of adrenal steroidogenesis is far more complex than was the case 30 years ago. Two things that I do want to point out here is number one, these steps in green showing in fact that it's now understood that you can get 11 hydroxylated androgens being synthesized at high levels in the adrenal gland, including 11 hydroxy, 11 keto androstenedione, and 11 hydroxy and 11 keto testosterone. These are active as androgens and may be physiologically relevant in congenital adrenal hyperplasia. The second is that there's a backdoor pathway, which is illustrated down here at the bottom in purple, which is a way of getting from 17-hydroxyprogesterone directly to dihydrotestosterone, which is a very active androgen without going through androstenedione or testosterone as well. And so in principle, especially during the prenatal period, but probably postnatal in affected individuals as well, is measuring androstenedione and testosterone may not be the full story, and you may have appreciable levels of dihydrotestosterone in poorly controlled individuals. We divide congenital adrenal hyperplasia. By the way, someone just give me a thumbs up or an okay if this is still working properly. We divide. Okay, I'm getting lots of thumbs ups. Great. Okay, lots of thumbs ups. We are congenital adrenal hyperplasia is divided into several forms: the severe classic form and the much milder or non-classic form, with the majority of classic cases being unable to synthesize aldosterone, which is salt wasting disease. Those individuals with moderately severe disease who can synthesize aldosterone adequately are referred to as having simple virilizing disease. You can distinguish between these by means of a cosentropin stimulation test. This is the classic nomogram with basal and stimulated levels here, with the idea that classic and non-classic cases are very readily distinguished from normals and carriers, but the test is really not reliable for detecting carriers under many circumstances. So non-classic individuals running roughly between 1,000 and 10,000 nanograms per deciliter of 17-hydroxyprogesterone, and classic cases being above 10,000 and going up to about 100,000 nanograms per deciliter. The genetics is also more complicated than was the case when the genes were first cloned in the mid-1980s. Again, I'm not going to go through this in detail. This is in the published endocrine reviews paper, but to indicate that there are two 21-hydroxylase genes on the short arm of chromosome 6, and they alternate with two genes of the fourth component of serum complement. The active gene is on the right, the pseudo gene is on the left. About 20% of deficiency alleles are deletion of the active gene owing to unequal crossing over during gametogenesis, during meiosis. The other genes are transfers of deleterious mutations from the pseudogene to the active gene. So the pseudogene contains a bunch of different mutations which can knock out enzymatic activity, interfere with enzymatic activity to a greater or lesser extent. And when transferred to the active gene may either cause knockout enzymatic activity, causing salt wasting disease, may knock out about 99% of activity, giving you simple virilizing disease, or may impair activity by 20 to 50%, giving you non-classic disease. CAH, due to 21-hydroxylase deficiency, is an autosomal recessive disease. So the phenotype in patients is that of the most affected, of the least affected mutation. So if you're a carrier, then basically you're asymptomatic. If you have one mild mutation, illustrated schematically here with the yellow X, that means you have non-classic disease. If you have two severe mutations or severe mutation and a deletion, then you have classic disease. So anybody interested in CAH, these are two articles that you should have in your library. I was the last author on both of them, which is why I think they're good articles. And one of them is the 2018 consensus statement on CAH, and the other, as I said, is a recent endocrine reviews article. If anybody is having trouble accessing either of these, please do feel free to email me. I assume my email is in the program book, or you probably know it anyway, and I'll be happy to send you an electronic reprint of either. A few things on the basics, just to review. Maintenance therapy, the mainstay of which is hydrocortisone, which one tries to hold in only modestly supraphysiologic doses. Physiologic hydrocortisone replacement is roughly 8 milligrams per meter squared per day. In general, kids with CAH require 10 to 15 milligrams per meter squared per day. Divided usually 3 times per day. Everybody with salt wasting disease and most individuals with simple virilizing disease benefit from fludrocortisone as a mineralocorticoid substitute, with very high doses in the neonatal period, often of 0.2 or 0.3, rarely more than that, milligrams per day, with older kids and adults often requiring much less. Sodium chloride supplements required really only in infancy. The normal Western diet is sufficiently sodium replete, and generally added dietary sodium is adequate under most cases, unless someone has a gastroenteritis or is otherwise unable to eat. So I indicated that glucocorticoid treatment often is required in somewhat supraphysiologic doses. And here are the reasons why. If you don't give enough, is you end up with excess secretion of androgen precursors from the adrenal cortex, and that can lead to signs and symptoms of androgen excess, including early puberty, and particularly premature adrenarche, hirsutism and amenorrhea in pubertal females, infertility mostly, but not solely, in females, with accelerated skeletal maturation, tall stature during childhood, but premature epiphyseal closure leading to short stature as adults. Whereas excess cortisol can have psychological effects such as depression or agitation, can lead to metabolic side effects such as insulin resistance or obesity, and can retard linear growth by itself and lead to short stature. So close attention to dosing is important, and typically the need to not normalize precursors like 17-hydroxyprogesterone or androstenedione, but to aim to have 17-hydroxyproj in particular modestly elevated, generally between the upper limit of normal and maybe 10 times the upper limit of normal. But if you have a low normal 17-hydroxyprogesterone, you are giving somebody too much glucocorticoid. In general, you want to normalize but not suppress androstenedione levels. This is just showing that typical schedules do not normalize anything here. This is looking at hydrocortisone levels just with conventional dosing with standard hydrocortisone tablets. In this particular slide, the largest doses being given in the evening, with despite this a peak of ACTH and of 17-hydroxyproj in the morning. And this is because normal typical hydrocortisone, which is identical to cortisol, has a plasma half-life of about 90 minutes. It has a much longer biological half-life, but it's still relatively short, and this means that it wears off. So the question comes up of when should you, how many doses of hydrocortisone should you give, and how should you divide it? And it turns out that it doesn't really matter. This is a recently published randomized study looking at giving the largest dose in the morning or evening. You maybe get very slightly better suppression of the 17-hydroxyprogesterone peak or the androstenedione peak. Sorry, the 17-hydroxyproj peak on the left and the androstenedione peak on the right. If you use a highest morning dose, which is what I typically do, but a high evening dose isn't really that much worse. I would give it at least 3 times a day. Some people give it 4 times a day. I think it's very hard to get good adherence when you do that, but I don't fault anybody who wants to try. So there are a bunch of different hydrocortisone or other steroid forms. I'm going to go over this just very briefly. Hydrocortisone tablets are what I said. They're cheap. They're the standard. They're relatively easy to get here in the U.S. Getting the 5 milligram size is difficult in many countries, which can be a problem. You can extemporaneously crush the tablet or a piece of the tablet and give it that way. It does not have a great taste, but with a little bit of applesauce, it'll work okay. Compounded hydrocortisone preparations are tried in many places. We do use them early on because we have a good compounding pharmacy in our hospital, but many places do not, and serious compounding errors have been reported using it. If I have someone out in the boonies, and especially if it's a kid, I do use prednisolone or pred, very widely available and relatively inexpensive. And you just use that at 1/4 to 1/5 of the hydrocortisone dose that you would otherwise use, and you can divide that BID. I'll get into this a little bit later. Many people think that prednisone should not be used. I feel a little bit more kindly about them than some people do. Alkindi is immediate release granules. It has the same pharmacokinetics basically as regular hydrocortisone, but allows you to accurately dose as little as 0.5 milligram of this stuff. The official price is extraordinarily expensive, meaning that if you look at GoodRx or drugs.com or something like that, hydrocortisone tablets are $15 to $30 a month. Alkindi is street price can be as much as $3,000 a month, although with insurance it doesn't cost that. So I personally will cheerfully prescribe it to anybody who asks, and if their insurance will pay for it, that's great. But I do not use it routinely because I think 200 times the price of the generic just for an alternative dose form is highway robbery. A couple of modified release hydrocortisone forms. The one that's been most actively tried, it used to be called Chronocort. Its new trade name is F-Modi. Remember, easy to remember. F is the old abbreviation for hydrocortisone, so it's modified F-Modi. Little dumb, you might think it has something to do with diabetes. It does not. You have to give 2 doses with 2/3 in the evening and 1/3 in the morning, and I'll get in, and this tells us what happens. So in both these slides, again, this is showing 17-hydroxyproj on the left, androstenedione on the right. The black dots are using modified release hydrocortisone. The open circles are using standard hydrocortisone. You see the peaks with of 17-hydroxyproj and androstenedione in the morning, and those are completely abrogated by using modified release hydrocortisone. The first trial has failed its primary endpoint because they were looking at mean 24-hour 17-hydroxyproj scores, and that was a kind of odd endpoint. It didn't work, but it looks as if it does work if you are trying to modify the peak of 17-hydroxyproj or androstenedione. Trials of this are ongoing. I believe the eligibility is changing, but I did not get a chance to see the email yesterday, but as things currently stand, is this remains under trial in this country for adolescents, and there's no real reason why it couldn't be extended to somewhat younger individuals. Remembering that you shouldn't break the tablets, so it has to be people that you can that you can dose in with moderately large doses of the stuff. There have been trials of using insulin pumps to give hydrocortisone. Expensive, obviously. You still need to give some steroid orally or systemically, because you don't want the pump to fail. And it's not like insulin where the blood sugar goes up if the pump isn't working. So I don't like this idea at all. Although it may kind of work. So getting back to prednisone. The last Cochrane systematic review, which was a couple of years ago, basically there weren't enough studies to really say much. Some evidence that in some contexts prednisolone might in fact be superior to hydrocortisone, but some post-hoc studies which Deb Merck presented last year at the Endocrine Society suggested that in a randomized head-to-head comparison with Chronocort/F-Modi, is in fact that prednisone worked less well than a equivalent dose of the Chronocort or F-Modi. So if you can, if that stuff does get approved, is that may be a really good approach to this. But for right now, I think the point is that people try prednisone or prednisolone generally in a biased manner with kids who they can't control well on hydrocortisone. And so, yeah, they're going to have to use high doses, and they're going to get more adverse effects. I don't really encounter those problems at all when I use low doses of the stuff in infants where I'm using prednisolone syrup sometimes. But I think we'll have to see what other forms become available and how expensive they are. I'm just going to cut ahead here just to show that a review article looking in the United Kingdom of a large number of adults suggested, in fact, that there were no more metabolic side effects with prednisolone than there were with hydrocortisone. That there was better control of 17-hydroxyproj, and no, really no difference for androstenedione, but no difference for insulin resistance. Whereas if you use anything with dexamethasone, you got better suppression of steroids, but you also got more in the way of metabolic side effects. Fortunately, I conclude don't use dexamethasone except under very unusual circumstances. But any combination with hydrocortisone or prednisone or prednisolone may be really okay. And in some kids who become hypoglycemic overnight, even if using hydrocortisone during the day, is prednisone or prednisolone may be a good thing to use overnight because it lasts longer if the parents are reluctant to wake up at midnight to give the kid another dose. Looking just in general, these are again studies from Deb Merck's group. There's not a control group here. The open bars are non-classic patients. The closed bars are classic patients, suggesting a few more overweight patients, but not a huge number in the pediatric age group. Maybe a bit more in the adult group. I think these are. I think in the pediatric group, this is very unimpressive difference between normals and obese, and also in adults, somewhat more individuals with at least mildly elevated HOMA-IR as a measure of insulin resistance than is the case for non-classic patients. Hypertension. Fludrocortisone should normally be monitored both with blood pressure and by measuring renin levels, with the idea again that you want to keep plasma renin preferably in the upper part of the normal range or mildly elevated. You want to be careful to not suppress renin. This is particularly problematic, in fact, in my experience, in infancy, because you have to give boatloads of salt and fludro to normalize potassium in neonates or very young infants. And then you have to watch very carefully at 2 to 3 months where the infantile kidney becomes more sensitive to glucocorticoid and better able to excrete potassium. Because I've had plenty of kids admitted to the hospital where sometimes they don't even call us. And the nephrologist could call in and put someone on a calcium channel blocker instead of backing off on their fludro, stopping their salt, which is what they really need to be doing. But regardless, is clearly there are more individuals who are hypertensive amongst people with CAH, and I think being careful to use the lowest effective doses of fludro is important on a lifelong basis. And in adults under many circumstances, is they may need really quite modest doses of this stuff, and some adults can even come off it. Testicular adrenal rest tumors, or TARTs, are I think becoming higher in my consciousness, at least in terms of potential side effects potential adverse effect of CAH. If you look for it with ultrasound, you can find them in about 25% of kids, and really almost half of adults. They can be small, as in the ultrasound on the left, or really very large, as in the ultrasound on the right. Obviously, these use are not of equivalent magnification, and may to some extent be related to poor hormonal control, certainly, as they do reflect chronic overstimulation with elevated ACTH levels. This is just a diagram from an endocrine review article several years ago, showing that if they are large, they can really cause peritubular fibrosis with permanent damage to the testes. So they may be suppressible with high doses of glucocorticoid as the first step. They may, in some cases, require microsurgery. I do caution all of my adolescent boys, especially if they're getting near graduation, is to make sure that if they should be doing self-exams, and make sure if they do detect something, or if another physician tells them that they have a testicular mass, is to make sure that the urologist knows that this is the highest thing in the differential, and avoids doing orchiectomy for adrenal rest tumors, which I have seen happen. I think at this point is all these as the thyroid nodules. These may be very difficult to palpate when they're small. And when they're large, they can be firm to rock hard masses in the testes. But I think that all males with classic CAH should get a baseline ultrasound sometime in mid-adolescence, and probably every few years thereafter. So I want to spend the rest of the talk going over cutting edge therapies, let's say. And I really want to give a shout out to Deb Merck and Rich Aukus. This is a diagram from their excellent review article in the New England Journal of Medicine a couple of years back. But I'd say the two of them have definitely taken the lead in trying to develop various new treatments for CAH. And the ones that I'm going to go over mostly are reducing ACTH levels using CRH receptor antagonists, drugs that block androgen synthesis or androgen effect. And I'll take a couple minutes at the end to talk about gene therapy. So this is our classic, my classic slide, just reminding everybody that cortisol secretion is normally controlled via a negative feedback loop at both the hypothalamic and pituitary levels. So cortisol feeds back up the hypothalamus to inhibit secretion of corticotropin-releasing factor or corticotropin-releasing hormone, and also at the pituitary level to inhibit secretion of ACTH. So one can use a CRH antagonist to block the hypothalamic to pituitary signal. It is not an efficient blocker, so it does not completely block ACTH secretion, but it can reduce it by, let's say, 50%. This class of drug was developed to treat depression and ended up not being effective for that purpose, and development was stopped. These things have been knocking around for 10 to 15 years, at least. So there are two that are in trials: crinecerfont being developed by Neurocrine, and tildacerfont being developed by Spruce. A full disclosure is we are one of the study centers for crinecerfont. I believe that Cook Children's, who are sponsoring the CME for this meeting, are using tildacerfont. There have been published 14-day trials and also 12-week trial of tildacerfont, but phase 3 trials are underway. The main drawback, to my way of thinking, is that you can't tell. So almost by definition, you can't tell if you're giving enough glucocorticoid, because these drugs will inhibit ACTH release, and so you can't use ACTH, and because that's what these drugs are supposed to do, you can't use 17-hydroxyproj or adenosine. You actually have to ask the patient how they feel, and that's great if they tell you accurately. But kids tolerate adrenal insufficiency really very well under many circumstances, and so I think we're gonna have to be very careful with these drugs if we do use them to really make sure that people are adequately stress dosing to make sure that we don't end up with more cases of adrenal insufficiency. Nothing thus far in the trials, as far as I know, but the phase 3 trials using long-term are underway. So the phase 2 trial of crinecerfont, which has now been published, basically showed 50 to 60% reductions of ACTH and 17-hydroxyproj, and somewhat lower dose-dependent reductions of androstenedione secretion. This is a 12-week trial of tildacerfont. What this shows basically is that if you're in good control, tildacerfont doesn't do anything. Okay, if you end up in bad control to begin with, like 17-hydroxyproj of 15,000 here, yeah, it'll normalize, or androstenedione of 1,000, yeah, it'll normalize it really well. But probably not drugs that we should be using in individuals who are pretty well controlled with modest doses of hydrocortisone or prednisone. Merck published this classic study over 20 years ago using flutamide as a first-generation anti-androgen, testolactone as a first-generation aromatase inhibitor, therefore being able to back off on hydrocortisone dosing, and showing in a 2-year study that it improved predicted height. This is, as we're talking about polypharmacy, this has not gained traction, at least in our center, as a standard of care. Although I think many of us do use aromatase inhibitors in pubertal boys with advanced bone age as a single agent. Again, uncontrolled studies using growth hormone plus blocking puberty with a GnRH agonist. I personally do not use this unless I have a kid who seems to have low growth hormone, where it does seem to be efficacious, but growth hormone is expensive, and the question of whether it does seem to work if in individuals where one is needing to use quite high doses of corticosteroids and it's having poor growth, as I have seen it work effectively, but I don't think the evidence is there to use it as a standard of care. Abiraterone acetate is an inhibitor of CYP17, 17-hydroxylase, 1720-lyase, developed for use in metastatic prostate cancer when a GnRH agonist is no longer adequate. Potently blocks 17-hydroxyproj and androstenedione, and this is where it works. So blocks conversion of pregnenolone to 17-hydroxypregs and then and hence to dehydroepiandrosterone. So it blocks synthesis of all sex steroids. So you have to be careful using this stuff in anybody with puberty, and in someone with normal adrenal glands it gives you 17-hydroxylase deficiency, so it blocks cortisol synthesis. You can make corticosterone, which is a less potent corticosteroid, and so you end up with high dope levels and will become hypertensive. So in individuals with intact adrenals, you have to suppress normal adrenal synthesis with prednisone. But in kids with 17-hydroxyproj, I'm sorry, with kids with 21-hydroxylase deficiency, that's not a problem, and it should work okay before puberty. In adult women, it works very well when used for a week in reducing androstenedione or 17-hydroxyprogesterone levels. And so we have funding to use this in prepubertal kids with CAH. I could take another whole hour discussing all of the roadblocks to getting the study done. It should have been done years ago. It is still active. If as the trial for crinecerfont is closed right now, if any of you have scientifically minded prepubertal kids who might like to try out this stuff for a week and see how well it works, please do send them my way. Just give me a call by email. It's being on drug for a week. We're still trying to get dose finding and get PK/PD with the idea that we would move on to a phase 2 study if those things are effective. Finally, I'm going to close with just talking for a couple of minutes about gene therapy. Everybody is into gene therapy. This is a study in mice showing that you can. This is using an adeno-associated virus for gene therapy. So this does not integrate into the genome. Okay, it's not like a lentivirus that actually reverse transcribes itself into your DNA. The viral DNA just sits there. So you can get remember, this is in mice. Okay, so you can get lots of 21-hydroxylase in the adrenal gland, but adrenal cells turn over, and so what happens is it's gone by around 6 months after administration. So one dose wouldn't do a whole lot. Nevertheless, there is a phase 1 study that is FDA approved, and it's listed in clinicaltrials.gov, and it is recruiting. I would not touch this study with a 10-foot pole. I do not think it is ethical. And the reason why I do not think it is ethical is that there are well-established ethical guidelines for trying gene therapy. And the main one is that it needs to be something where it's a really bad disease and where there's no good therapy. So gene therapy for adrenal leukodystrophy, hell yeah. Those trials have happened, and we can hardly wait to get our affected patients onto adrenal leukodystrophy treatment. But for CAH, I mean, come on, we have perfectly good drugs, and there are a couple more drugs that have been just approved in the past few months, but there's only one drug, to the best of my knowledge, that uses an adeno-associated viral gene therapy system that's FDA approved, and it's a drug that's used for spinal muscular atrophy, which is a fatal disease. This drug carries a black box warning for acute serious liver injury. It costs over $2 million per treatment. It is approved for only one treatment at a time. And because of the way it works is you will generate antibodies against the vector if you try to use it more than once. So remember, I showed you that it turns over in the adrenal cortex when this is used in mice. So this is going to be highly temporary. So for the life of me, I don't understand why this trial is going forward. So the first thing is to back off the sodium chloride, and the next thing is to rapidly back off on the Fludro, recognizing that you may have to tolerate a high-ish potassium. And so this may require frequent monitoring of electrolytes. You may well need to tolerate a potassium near the upper limit of normal. Okay, I'm glad that you can all hear me. I personally think that it's rarely necessary to add another antihypertensive. And so the goal is to monitor these kids very, very frequently early on, and to try to stand there with crossed arms between the patient and the nephrologist to avoid unnecessary dosing with additional medications. I've even seen kids be on Fludro and a mineralocorticoid receptor blocker, which makes no sense at all. But that's and you know, past infancy, you know, as I think we're all aware, while I'm waiting for another question, past infancy, as I said, in general, the normal American diet is so sodium rich that as long as kids have unfettered access to dietary sodium, it's not a problem. I think it is important, however, when you have kids who are sick, is you need to make sure that they have unfettered access to both carbohydrate and salt, because although past infancy is hypoglycemia should not be a big problem, as it certainly can be in someone who's badly stressed and who's febrile. So I was reading a chat at the same time. So I think using you know, Gatorade or you know, or Pedialyte, or even you know, regular Coke and saltine crackers or something like that, something that the patient can tolerate if they have a gastroenteritis. I think in addition to actual stress dosing, of course, is I think that dietary carbohydrate and dietary sodium are both extremely important in sick patients. If you have a kid who cannot tolerate oral treatment, that is where they need to be using their injectable hydrocortisone and heading on in to the emergency room to get some IV D5 or D10 normal saline. The next question was from Ayana Batlasifas asking about weaning kids off Fludro. Well, I think it's a question of what. So you know, I put up all the stuff about genetics because I like it. As a practical matter, is in many locales, is it's difficult to get genotyping paid for by insurance. I think it's useful to know what the mutations are that a patient carries, recognizing that the genotype phenotype correlation isn't completely adequate. So that you have plenty of people who are really salt wasters, who are really simple virilizers, who may nevertheless have mild electrolyte abnormalities early on. So just because someone had electrolyte abnormalities as a neonate doesn't, you know, they may really, air quotes there, be simple virilizers. And so, you know, if you wean down on the Fludro to to half a tablet or quarter tablet every other day, and the kid is just fine, and you don't have genotyping data, yeah, you can take them off. Some people feel that you may get better control of 17-hydroxyproj with a little bit of fludro. So I think that whether you wean someone off should depend upon whether or not you're not happy with the blood pressure. The blood pressure is high on very modest doses of fludro, and you don't have genotyping data. So I think it's perfectly reasonable to try to wean children off, assuming that you can then keep their hydrocortisone doses in a reasonable range. There are some adults who have if you're going to be fully non-adherent, okay, so not taking your glucocorticoid very well, you'll end up with high circulating levels of progesterone, okay, and that'll get converted into liver into some deoxycorticosterone, which has salt retaining activity, and maybe even a little corticosterone. And so if someone has adrenal glands and they're really taking little or no medicine at all, they may get away with it. That's not quite the same thing as if someone is well controlled with their glucocorticoid. I don't take them off fludro unless they're running highish blood pressures on very low doses of the stuff. Excellent. Any other questions? That's a thank you.